Welcome to the MS-Perspektive podcast. Perspective with a K, as I'm German. I'm Nele Handwerker, MS patient, patient advocate and author. I'm bringing you interviews, inspiration and information about living with multiple sclerosis and show you ways how you can positively influence the disease and make the best out of your diagnosis. On ms-perspektive.com, you will find the show notes, 11 free tips as a PDF, and lots of other information. And now the show begins.
This podcast is supported by Mid-Mission, a project of the nonprofit Hertie Foundation.
Thanks for tuning in again, and welcome to episode number 52, Sequencing and Escalation in MS, Navigating Treatment and Progression with Professor Tomas Kalincik. Professor Tomas Kalincik is Group Leader and Head of Neuroimmunology and MS and Professor of Neurology and Applied Statistician at University of Melbourne and Royal Melbourne Hospital in Australia. And now enjoy the interview. Hello, Thomas. It's such a pleasure to have you on the show today. And I send a hello to Australia, to Melbourne.
Hi, Nella. Hello from Australia, and thank you for inviting me to join you on this conversation.
Yes, and before we actually start with the interview, it would be lovely if you could introduce yourself to the audience so they know who is with me on the podcast today.
With a pleasure. Dear ladies and gentlemen, my name is Tomas Kalincik. I'm a neurologist in Australia, in Melbourne. I'm the director of the Neuroimmunology Centre at the Royal Melbourne Hospital, which is a dedicated neurology centre which looks after people with MS, but also with other neuroimmunological conditions. And also I am the head of Clinical Outcomes Research Unit, also known as CORE, at the University of Melbourne, whose focus is on analysis of observational data and translating data into evidence.
Yes, and that's very important. And how did you ended up there? What was your personal motivation for this kind of career?
I always wanted to work with brain and clinically work with brain, but I was looking for a research challenge, and I have tried a few different research areas. What attracted me to neuroimmunology, especially to MS, is the fact that it is a big problem affecting many people. And I have joined the field at the time when I have seen emerging success, where there was around the time where natalizumab was becoming available. It was very exciting times, and seeing an area in neurology where progress was being made so fast and so dramatically was a very appetizing perspective. So we saw at that time registries emerging, large data set emerging, and I was realizing that there is a lot of signal that is buried in lots of noise that comes from everyday, real life, real treatment of real people with MS. And with my propensity towards statistics, I always wanted to use these advanced methods to separate the true signal from the background noise. And that's how I ended working in MS.
Yeah, sounds good. And before we actually go into the deeper understanding of everything, I would like to start with some basic knowledge, understanding MS progression and treatment effectiveness. What is the natural course of progression in multiple sclerosis, and what factors contribute to disease advancement?
So that is a very complex question. If we think about, traditionally we have thought about MS or the causes beyond MS as two camps: the risk factors for so-called disease susceptibility. So in other words, what makes someone develop the disease and someone else not develop the disease? And then the other camp are factors that leads to progression of the disease, worsening, accumulation of symptoms, and new damage to the brain and the spinal cord. So we have learned traditionally about the former group of risk factors, which, interestingly, it's important to remember that we typically speak about associations because defining causation in risk factors for MS susceptibility is very difficult. But what we have learned is that there are factors that are very strongly associated with the risk of MS. Factors such as geography, latitude, in which people live. And I tend to view that as a label that stands for something else. Why certain latitudes higher latitudes make people more at risk of developing MS remains a mystery. And there could be involvement of sunshine, it could be sun exposure, UVB radiation exposure to be precise, or there could be pathogenic composition of the viruses and bacteria in certain locations around the globe, or it could be the genetic composition of the populations living in those areas. So that leads me naturally to these other risk factors, such as vitamin D levels, for example, which are closely associated with UVB radiation that comes to us from the sun. We notice that most people at the time of diagnosis have very low vitamin D levels. And therefore, the risk factors of worsening of MS, there are some that are intertwined with the so-called susceptibility, such as high BMI, people who have larger body mass are at high risk of developing MS. And there were beautiful studies done in Norway that showed to us that people in 1960s and 70s who were screened as part of a TB screening program with X-rays and had their BMI documented, so body mass index documented at that time, those who had higher body mass index, especially children, were at higher risk of developing MS further down in their life. And smoking. Smokers are definitely at a high risk in general of inflammatory and autoimmune diseases. And these two factors also propagate into the higher risk of more severe cause of the disease. From clinical practice, and there is only scarce data available, I noticed that certain ethnicities tend to suffer from more severe causes of MS. I see this a lot in people from Middle Eastern areas or from Sub-Saharan African areas. And of course, there must be a strong involvement of diet in the risk of more severe or possibly or option of less severe disease. But this is a very mysterious area because it's very hard to disentangle diet from everything else that a human does in their life. And we can see that while we are able to say with confidence that diet is implicated in the severity of MS, we can't say which diet is the right diet. And you will see that when you go through the list of diets that different people recommend, which vary from pescatarian or vegan diets all the way to the opposite end of the spectrum, the paleo diets, which are mutually exclusive. So there is an area that requires a lot of research and very difficult research to carry out. So that is my long-winded answer to a very complicated question.
Yeah, sorry for starting off with that. And by the way, there is a lovely interview with Claudia Mark on smoking and how to stop smoking. She is in Australia as well. So just for the listeners, maybe you want to listen to that interview. It's at the beginning. I don't know the number right now, but it's very important. And I can't give good advice because I never smoked. Luckily. But okay, let's come to the next question. Which aspects of MS can be effectively managed with current treatments, and at what stage is treatment most effective in addressing inflammatory processes and preventing disease progression?
Yeah. I like how you phrase the question, Nella, because I think at this day and age, what is a sign of time the last 2 years is as a movement away from this slicing and dicing of the disease into these very discrete categories, such as relapsing or remitting MS, secondary progressive MS, primary progressive MS, which still holds some value. But we have learned that it's very difficult to draw boundaries between these different disease types. And from that, last year, there was a communication in Lancet Neurology that was already pointing us in the direction that rather than categorizing the disease, we should be classifying the different processes underpinning the disease and trying to quantify those processes and recognize that some processes are better responsive to some types of therapies and other processes to other types of therapeutic approaches. So far, our therapeutic approaches have focused on managing the disease that is propelled by this episodic localized inflammation. That's the hallmark of relapsing, so-called relapsing remitting MS. This is a disease that presents with relapses, so episodes of symptoms, new symptoms, or worsening of old symptoms that last for a certain period of time and gradually over time improve. In some people more quickly, in some people at a slower rate. And there are some treatments that can facilitate the quick improvement that help shut down the blood-brain barrier and shut down the inflammation fairly rapidly, such as infusions of corticosteroids. And these therapies in general have been really the focus of the development of drugs for the first 15 or 20 years of research in MS. And this is where I'm talking about the spectrum of so-called disease-modifying therapies ranging from interferon beta and glutamate acetate to the most contemporary therapies such as natalizumab, ocrelizumab, ofatumumab, alemtuzumab, which are monoclonal antibodies, highly sophisticated molecules that specifically attack the focus on a certain antigen on the surface of cells and thereby modulate how our immune system works. We have become quite efficient in preventing these episodes of focal localized inflammation to the point that we are able to prevent with the most potent therapies about 60 to 75% of these events that otherwise would have happened. That is very nicely illustrated by the trends that we see in large registries, whether national registries or the MS-based international registry, where 15 years ago, the average number of relapses that a patient would experience in a year with MS would be around 0.6 or 0.8 relapses per year. Whereas nowadays, the baseline relapse rate ranges from 0.2 to 0.3 relapses per year. And that only speaks to the proactive approach and the effectiveness of managing or preventing these issues. However, the second part of the story is the story of more insidious, slow worsening that happens in the background. And I like to think of it as a continuum. Some of that we can see and we can measure with disability scales such as EDSS, or with specialized tests that allow testing of fine motor skills of the hand or walking speed, or cognitive function, which is a function of memory and higher processing function. And some of these changes we can see on, for example, MRI of the brain in the form of gradual, slow loss of brain tissue, but faster than what one would expect for a general population. These processes that are not visibly driven by this episodic focal inflammation are very hard for us to control with the current medication, which so far has really focused on controlling that episodic and focal inflammation. And the whole scientific and clinical community is now really energized to invest a lot of focus, attention, and research activity in that area of understanding what fuels these slowly progressive processes and where we could break the chain, where we need to hit those processes to abolish them in an individual. The problem in that research is again complex. One is a process that we do not fully understand, but I'm very excited that over the last 2 years we have made very significant advances through understanding of things such as viral involvement in some of those processes. EB virus, Epstein-Barr virus, which is a virus that causes infectious mononucleosis, is now thought to be strongly involved in the susceptibility to MS, so the risk of one developing MS, but also potentially we are exploring whether it could be still implicated in the progression of MS. And also the roles of cells, immune cells that infiltrate the brain in the life with MS, and they settle there and they become what we call resident immune cells. Could these be cells that fuel that slow process, in which case, if the process is inflammatory, these cells make themselves a home behind sealed blood-brain barrier, which is a very tight barrier and doesn't allow larger molecules and cells to come from outside the brain to inside the brain, which would make therapies such as our highly sophisticated monoclonal antibodies ineffective. And we need to think about the ways how to get the therapies to where they need to be and still affect the cells that sit inside the brain. So it's very exciting time. I think I'm anticipating that in the next 2 or 3 years, we will learn a lot more about these processes. We will start seeing more therapies that are specifically acting on the inflammation that's hidden inside the brain and potentially fueling these changes. And what we are also passionate about here at Neuroimmunology Center at the Royal Melbourne Hospital is exploring the hidden part of this slow process. I spoke so far about that visible part, which presents with change in disability, slow accumulation of new symptoms, or visible changes on brain MRIs. But I believe that there is a hidden element that oftentimes we do not see. And I do reflect on that in conversations with people with MS when they sit in the room with me and they say, "Hey doc, there's something it's not 100%. Something's happening. I can't quite tell you what's going on." And I try hard. We do all the assessments. We look at MRIs. We can't find evidence of deterioration. And then we say, okay, no, I'm not dismissive of that statement. I say, I believe you. There's something going wrong. I'm not able to see it, but you know about it. And then oftentimes we look back 5 years down the track at that moment in time and we realize, okay, remember that time I told you there was something going on? Now we can see clearly that over the last 5 years, this has resulted in deterioration in my clinical status. So what we want to learn is how to quantify, see, and measure that very subtle change before it becomes clinically apparent. Because if we can measure it, then we can answer the question whether the treatments that we are using are targeting that slow, subclinical, or latent, if you wish, process before it becomes clinically overt. So that is one strong area of focus in our research at the present time.
Very good, yes. And I try to use certain words a bit more often so people get used to it. And I use for that word the neurodegeneration. I always have problems with pronouncing it correctly as a German. But yes, that's a very complex thing. And I think it was quite obvious at ECTRIMS. Some people pointed it out very clearly that people at the beginning thought, hey, if we can control relapse activity, fantastic, we will be done. I think it was even Stephen Hauser at his talk. And then we could control relapse activity quite good. And unfortunately, there was still that hidden neurodegeneration or deterioration. Another important aspect is that our immune system changes with age. What implication does this have for the MS progression and treatment, considering the change in effectiveness and risk of side effects of disease-modifying therapies?
Yeah, so you're probably alluding to the whole spectrum of very active immune system in the childhood, all the way to the other end of the lifespan, that is the immune senescence, so-called immune senescence, so the decrease in or decline in the activity of the immune system. That is a very interesting phenomenon to understand and drive. And in simple terms, quantitative processes, as I described, children have highly active immune system and older people have less active immune system. We do see that very clearly when we look at data in large databases from people across the spectrum of their lives and study the risk of relapses. We see that in people around age 18 or younger, the frequency of relapses is very high. In people after age 60, 65, the frequency of relapses becomes much lower. And also, interestingly, we see a difference in the frequency of relapses between men and women. So while the curve is a decline over the lifetime, also there is a separation of sexes. And the separation becomes most apparent around time of puberty. And interestingly, and around the time of menopause, that separation starts to disappear again. So we think that there is a hormonal involvement in this of some sort. And this has been a hypothesis for some time, that so-called low estrogen state, that is a state that a woman experiences through a large proportion of her fertile life, is conducive of pro-inflammatory state, whereas high estrogen state, such a state that a woman experiences during pregnancy, would be more immunoprotective or protective from autoimmune processes, or anti-inflammatory, so to speak, which is a hypothesis that has been tested in animal models, and there is possibility of exploiting this in clinical trials. That's the quantitative perspective, the amount of inflammation. I can't speak to the qualitative changes. There are people who are much better placed to do that, and I'll be fascinated to learn more about how qualitatively responses to change. So, for example, is the inflammation in children more driven by the adaptive immune system, the immune system that rests on antigen-presenting cells such as dendritic cells that collect antigens from circulation and present it to T and B cells, which are lymphocytes that are part of this adaptive system that learns about the environment and interaction of the human body with the environment. And where, on the other hand, possibly in elderly people, it's more the innate immune system that takes over that is more important. These are cells such as cells that are naturally present in the body with immune properties. One of them is very aptly called natural killer cell, and it is a cell that really its job is to identify the target and destroy it. And whether these different, I'm not sure. As I said, I'm not able to speak to how qualitatively different these processes are at the different stages of life. But if they are different, are these different qualities of the processes also responsible for the different types of presentation, as in frequent relapses versus less frequent relapses, but more pronounced progression of disability at various different stages of life? What further clouds that view is the fact that children and young people have more brain to spare. There was, in inverted commas, there was a bit of tongue-in-cheek statement, but you see what I mean. There's more reserve capacity in the human central nervous system when we are young. And a hit to the brain can be absorbed by the brain or the spinal cord more easily at that time, when there are other neurons around that can relearn the function of the damaged neurons. And also where the neurons are used to relearning the so-called plasticity, because plasticity is something that is very prominent in children's development. Whereas once the imprint of the brain is cast in later life, in later adult life, then the neurons are much less willing to relearn their function. They kind of set and they follow the set pattern. So the regenerative capacity, or the capacity to take over a function of other damaged parts of the nervous system, becomes much less prominent. That's why probably an older brain is more vulnerable to inflammatory damage than a younger brain. And of course, there is other cumulative damage, of course, that comes into play. And there's damage that we accumulate throughout our life, either through self-exposure to smoking or through things such as other conditions, metabolic conditions, medical conditions, stroke, all sorts of other influences. So I'm really curious to see what the research of the qualitative changes in the ways of immune response will teach us about how we should treat MS at different stages in life, and perhaps whether there are different therapies that should be predominantly used in children versus other therapies that should be predominantly used in elderly people.
Yes. Yeah. And so far, I had just for the German podcast a very good interview with Barbara Kornick from Austria, who is an expert in pediatric MS. And just to, because there will be, of course, a session in the English one, but just to make that clear, it's really important to treat these children, even so they can repair better, but if it's not treated, they end up earlier in progressive status, and that, of course, is something we want to, as best as possible, prevent. And with the older people, as you just explained, just for a summary, I think it's important that as inflammatory activity is not as high, to make a good choice whether it makes sense to use disease-modifying therapies or concentrate on the relapse activity versus maybe, hopefully, soon to come, medications who will concentrate on the other aspects of disease progression. What methods are currently available to predict who will experience high disease activity versus mild MS symptoms? For example, I have really a mild MS course. I'm in the disease since 20 years. I'm pregnant right now, so not taking a medication because I have thank you, I have a mild course. But yes, so there are some things where you say, okay, looks like this will be an aggressive one or a mild one, because you have to make these decisions at the beginning, I guess, best possible.
Yeah. I guess different aspects of the disease are differently amenable to prediction. What we have, for example, learned, we have constructed a model that brings together lots of different signals, namely 52 different variables fall into these large predictive models. And what we have tried to predict was things such as the rate at which one accumulates disability, or the probability of experiencing a relapse, or probability of developing more progressive form of the disease. So one thing that we have learned is that MS is very hard to predict. And I like to say, based on one particular study in which we looked in the past and in the future from certain disability milestone, which corresponds to the time when people start using a walking cane to walk at least 100 meters. What we have learned from that is that the tempo of disability worsening before that time point and after that time point are completely unrelated.
Okay.
So I guess that the negative view, the glass half empty view of that would be we are very bad at predicting what's going to happen in the future. The glass half full view is if you've had a bad course of MS so far, you're not doomed. This can still change in the future. And what we have seen in that particular analysis is when we tried to analyze what defines how quickly one will continue to accumulate disability after the time point that mentioned the use of the walking stick. The most important determinant was the use of highly effective therapies. So that's a great message. That means that we can still reverse or significantly modulate the course of MS, even if your experience so far has been very bad, with lots of disability accumulation over a short period of time. So from that, we have assumed the position that MS is an amnesic disease. It tends to forget about its past to a certain extent, probably not completely. For example, one hypothesis, one that you alluded to in your previous comment, Mola, that we tested was that the amount of inflammation that one experiences in the earliest years of life with clinically overt MS will determine how quickly they will accumulate disability much later in life once MS is labeled as secondary progressive. And we found no association between the early relapses and the rate of disability worsening at the later stages. To my disappointment, that was my hypothesis that the rate of worsening in secondary progressive MS is determined by early inflammation and therefore preventable by very, very proactive approach to treatment in very early stages of the disease. But as science goes, every scientist should be prepared to refute their favorite hypothesis in the face of data.
Yes.
And that's exactly what I did. And again, we expanded that analysis to look at what then modulates that accumulation of disability. And again, was the same signal that use of highly effective therapies during the later stages, once the disease is progressive, is the best way to prevent further disability from evolving. This is not equally valid across everyone with MS, and there is a so-called treatable target. If a person experiences progressive disease or predominantly progressive disease, but with superseded episodic inflammatory activity that is presenting in the form of either relapses or lesions, then they will benefit from highly effective therapy more. Whereas in people who only experience the slow progressive course of a disease, even highly effective therapies currently available with the current mechanisms of action, we're not able to mitigate the rate of disability accumulation at those later stages of MS. So that is answering a question of prediction through looking at the so-called phenomenology of the disease, so how it behaves at different, again, relating to the previous question, different stages of life with MS, and how one compartment, so to speak, of the disease feeds into another compartment of the disease. If we explore purely the predictive models that I mentioned earlier, not only ours, many other teams have built their own predictive models. SEMCAT has done excellent. SEMCAT in Barcelona has done excellent work in developing predictive models for prediction of outcomes early after the disease onset. So what we see is that we are reasonably good at predicting how frequently someone will relapse, which has a limit. It has a horizon. We are not able to predict that indefinitely. Probably, I would say up to 4 years, we are reasonably okay at predicting the frequency of relapses. But of course, these are only predicted on certain assumptions, under certain conditions, such as that the patient stays on the therapy that they are taking at the time of prediction. But of course, the reason why we do the prediction is to change the treatment in the future.
Yep.
So that we prevent bad things from happening. And that only tells us, as a statistician, we relate to this, basically what it means that we think Bayesian statistics is statistics that doesn't only look at the distribution of data and from the data calculates in a very contorted way the probability that a hypothesis, if we run 100 experiments and the hypothesis is true, what proportion of those experiments would show the results similar to the results that we are seeing in this present experiment. So you can see the explanation is quite complicated in frequentist statistics. But this is not how we think. We think Bayesian. We think about so-called posterior probability. So if I'm the patient with MS, what is my individual probability of having a relapse in the next year? Is it 20% or is it 5%? That's a Bayesian statement. And the Bayesian statements actually have the advantage of bringing together individual data with all our previous experience, all our previous predictive models. That's how we think. And that's actually what a clinician does in their room. They see the patient, they think about what's happened to this patient last time and what do I know about this disease? What does the evidence tell me? And then synthesize all the information together and then make a prediction about what's going to happen over the next 1 year and how they should therefore modulate the treatment to prevent things from happening. And this is really the way in which we are heading now with the predictive models, to try to integrate this information while respecting the boundaries of predictability or unpredictability of some components of MS, but trying to shed some light on these probabilities, give people a probabilistic estimation of what is the risk of having a relapse, having a worsening of disability in the future, or experiencing the disease that becomes more prominently progressive. And then the second step after that, which is something that we're currently working on, is to predict these conditional futures depending on treatment decisions. So it's like creating parallel universes for every person. And we say, in this universe, you're taking glatiramer acetate, and in this other universe, you're taking dimethyl fumarate, and in this other universe, you're taking natalizumab. And let's now compare what your future will look like over the next year or two in terms of relapse frequency and likelihood of accumulating disability or developing a progressive disease, given that you make the decision A, B, or C. And that's where we are heading towards more granular prediction, the prediction of individual treatment responses, which is the instrument that a clinician needs in presently in the absence of of clear evidence of what is a prediction. We currently do not have individual predictors of individual treatment response. So this is something that we need to establish to guide the treatment more accurately.
Yes, and this is something actually my neurologist, I think, is working as well quite a lot with his digital twin, Charles Thiemsen. And actually my husband is a physicist. So kind of it's getting into parallel universes and parallel, yes, realities. Very interesting. I love that. Even so coming from marketing, but I love that because that actually helps us as patients. You made a fantastic movement to the next questions, where I want to talk a little bit more about now treatment approaches and strategies. What are the key inflammatory processes targeted by the disease-modifying therapies, and how do they influence the MS progression? Just, I want to have a repetition on that so people actually realize, okay, something is coming from the periphery versus staying in the central nervous system.
Yeah. I guess I built my answer on a piece of information that I provided a few answers earlier, and that was about the innate immune system and the adaptive immune system. So these are two important components of the immune system. Each of them functions on different principles. So innate immune system is quick to respond, is there, attacks at will, but is not learning from the previous experience, whether the adaptive immune system is the immune system that we develop in our lifetime. And that's actually probably a very important part of the pathogenesis of MS, because one of the cells that is essential, that is critical, central in the adaptive responses, as we have learned from Royal Martin's work 6 years ago, is B cell. Before, we thought about B cell as a cell that is a antibody factory. And we knew that people who were treated with therapies that eliminate B cells, like rituximab, and from Stephen Hauser's work also, more contemporary molecules such as mucrolizumab and more recently ofatumumab, that these molecules actually control MS very effectively. How is that possible if the only role of B cell is making antibodies and MS is not an antibody-driven disease? And that's where Royal Martin's discovery of B cell orchestrating the response of the other cells around, being an antigen-presenting cell and really talking to the T cells about how to basically preparing the strategy of attack on the brain, how the B cell is really important central element, and then eliminating that element is in the periphery, in the circulation, is a very important step to sort of mitigating that preparation of the attack that is happening outside of the borders of brain. It's like armies that are gathering in the blood, getting ready to attack the brain and the spinal cord. So this is disrupting the process before the armies actually invade the territory of the brain and the spinal cord by eliminating the B cell. And interestingly, B cell is a target of a virus that I've already mentioned, the Epstein-Barr virus. It's a virus that causes glandular fever and then settles and rests in the B cells. And we don't quite, it's a bit of a, we know a fair bit about how the virus sits in there, and but we don't quite know the detail of what it does there and how it influences the B cell. But it's a very tantalizing, tempting prospect, thinking that the way that these cells are modulated may result in some sort of immune damage further down the track. And actually, a very recent work from Austria, from Vienna, showed which is a collaboration between virologists and neurologists, with Thomas Berger being involved, showed that failure to eliminate B cells that are infected by certain strains of EB virus, and they are targeted against molecule inside the human brain and spinal cord, may lead to MS. And this failure to eliminate these cells is more common in people with certain genetic composition. Now, also, B cell has a receptor. The EB virus has a molecule on its surface that is quite similar to one of the molecules inside the human brain. And also, it has a receptor or antigen or molecule that is quite similar to vitamin D receptor. And now you can see that this just reminds me of my favorite writer Hermann Hesse and his the Pearl Game book. You know how where you start linking the dots and these bits and pieces of evidence are starting to come together. I think these are really exciting times where there's these jointed pieces that I presented to you in response to the risk factors, question about risk factors of MS, are now actually starting to centralize themselves around a certain part of the immune response that is all orchestrated in the periphery with a B cell in the center of that cell being affected by a virus that potentially modulates how it works in people who have a genetic predisposition to a insufficient elimination of the modified B cells from their circulation. Interestingly, in people without MS, these cells also appear, they get infected by EB virus, and they also are targeted towards molecule inside the brain and the spinal cord, but they do get eliminated very quickly by natural killer cells. So this is where the other component that I mentioned comes into play. Natural killer cells is part of the innate immune system, and also other elements in the innate immune system that are probably more the responsive arm, the doer of the immune system. So think of the adaptive immune system as the coordination center of that attack, and the innate immune system are the armies. These are the forces.
Soldiers. Mm-hmm.
Yeah, exactly. Oversimplifying it, of course, adaptive immune system also plays some role in the execution of the immune response. But if you then think about it, then the adaptive immune system, once it finds a place and creates a center, a new logistic central somewhere in the brain, either around a vessel, and we are learning that these cells, B and T cells, do settle inside the brain, particularly in later stages of the disease, and become tissue resident. And then they are surrounded by these more peripheral standing armies of innate immune system that slowly expands the existing lesions. And these are the recently plentifully discussed slowly expanding lesions, or the paramagnetic rim lesions that we see on brain MRIs. Then this could be a very clear link between those two systems, and also the bridge from the periphery, from the circulating immunity to the brain, and what happens behind the blood-brain barrier. And you can see that with enough time, if there are enough cells from this adaptive immune system that make it to the brain and keep directing the innate immune system inside the brain, there would be a critical volume of infiltration of the brain to be causing slow, gradual destruction of tissue in the form of slow expansion of lesions, or subtle loss of tissue volume at many places around the brain at the same time, which you can imagine how that would lead to gradual accumulation of disability, and therefore would be called the progressive form of MS.
Yes, very good. And I like your making it easy with the metaphorics, because for most patients, I mean, I'm studying now since 1.5 years multiple sclerosis management with all these neurologists, but I think for the normal MS patient, it helps a lot if you do these easy to understand pictures, if you draw them. And even of course, I can learn always quite a lot when I have interview guests like you. Another question. I mean, you were talking already about the personalized MS treatment. How much is it based on evidence-based medicine and available biomarkers, and what might be coming?
The polite answer would be this is the area of unmet need.
Okay.
So it's really something that I'm really passionate about. I really like to focus on. We are kicking off a project where we will be recruiting a large number of people and studying their disease forms in depth with a number of different instruments that are contemporary and complementary. And that is in response to the fact that currently, we do not have a silver bullet, and I don't think we will ever have. What I mean by that is there is not a single marker that will predict the disease or that will predict the response. There are a number of times that we believe that we already have it, like brain MRI lesion, like brain atrophy, like serum neurofilament light chain. But we know that they are predictors of certain phenomena in certain people, and they're pretty better in some subsets of populations rather than other subsets of populations. And this is what we're learning. And by saying subsets, that means that these markers then can't be taken as predictors on their own. They need to interact with something else. So what I see as the next step is we learn to sub-stratify this pool of people with MS. Let's say people with certain genotype, so-called HLA genotype, or look at separately as sexes, female and male. And let these markers interact with the stratifiers and look at in which subpopulations these markers are more accurate and in which other subpopulations we need to look into other markers. And then that also leads us to another level of interaction, and there's interaction between different predictive markers. You would have heard about GFAP, for example, as another predictive marker that is soluble that can be found in blood and cerebrospinal fluid. So learning how the volume, the levels of NFL neurofilament light chain in blood are interpreted in the context of different levels of GFAP in blood is also an important factor. Maybe higher levels of both have a different predictive meaning to higher level of just one of them. And whether this ultimately, this complex interaction of the network of interaction between different markers of cell destruction, and where I believe is a lot of potential is interactions among different elements of the immune system. And Heinz Windel is doing fantastic work in that area. How understanding this actual involvement of different cells and different molecules that drive the immune response tells us which is the therapy that an individual in the room with me is likely to respond to such and such therapy. Just to give you a very concrete example, if we are able to identify deranged type of a B cell or abnormal natural killer response to a deranged type of a B cell, then I would expect that an individual with this immunological profile would most benefit from a therapy that eliminates their B cells, like rituximab or crolizumab or whatever. If we, for example, see another individual where the B cells are being eliminated appropriately by natural killer cells, but they do lack T regulatory cells, which is a cell that modifies the activity of other immune cells, and it's this is the peacemaker of your armies, and this is the cell that walks around and say, okay, hey guys, calm down. There is no reason to attack. And let's say there is a person in an individual who does not have the T regulatory cells. Then in that person, you would want to have to develop a tolerogenic approach. So you would like to develop a way to teach the immune system to tolerate certain molecule. And you can either program, or you can either make T regulatory cells and infuse them into this patient with a specific message. This is the antigen you should be protecting, not attacking. Or you can modulate antigen presenting cells like dendritic cells and teach them this molecule is a friend, leave it alone. Where currently there is no such message in the person's immune system. The message is lacking. So you can see how and I'm talking about the thing what this trickles down to is the first patient that I described, that example, would be treated by infusion of monoclonal antibodies that eliminates B cells. The second patient would be given an infusion of cells derived from their own immune system that teach other cells to be calmer and tolerant of certain molecules in their body. So this is where I think the future lies. There's a lot of work that needs to be done, but we are, again, living at very exciting times where I can see the foundations for this approaches to treatment already being laid.
Yes, and that's always something when patients with new diagnosis are asking me. I always try to explain them. It's best to have the diagnosis as late as possible because research is moving on and becoming faster and faster. And let's say it's the luckiness of late birth or late onset of MS, because if you had the diagnosis in the 1970s, there was not much you could do against it, and nowadays more and more approaches are coming. Another topic: can you explain the concept of flipping the pyramid in MS treatment, and where high efficacy therapies are initiated early and de-escalated maybe later in life?
Yeah, that is a concept that responds really to that epidemiology of inflammatory type of MS that I described earlier. The fact that children and younger people with MS tend to relapse much more frequently, so they have this very prominent episodic localized type of inflammation. And the therapies that we use are primarily targeted against this type of immune processes. So it makes sense that in this population, we use more potent therapies. So we trigger a potent response. That is not yet what I would call a induction therapy. So that is that is the base of the pyramid that sits on top. Induction is basically starting with high efficacy therapy with a protracted long-term effect, such as alemtuzumab, which leads to decade or maybe 2 decades of immune modulation or maybe permanent change of the immune system. Another immune reconstitution therapy is cladribine that leads to long-term changes. And we are yet to learn about what long-term changes are triggered by consistent depletion of B cells with B-cell depleting therapies such as the ones that I mentioned, rituximab, ocrelizumab, and ofatumumab, over the long term. Are these therapies same as therapies that only act while people take them, or do they also lead to some sort of permanent reprogramming of the immune responses? So one could use, this is the basis for the flipping of the pyramid, for the induction of treatment, and assuming that this leads to some permanent changes that are long-standing. And on the basis, then on the background of this treatment, then later we introduce therapies that are milder and more short-lived in terms of their effect on the immune system, then only add some additional degree of modulation of the immune system after the immune system has been changed more substantially by this more potent therapy in the past. I think there is a good rationale for this approach. There are also good reservations, valid reservations for why we need to be cautious. These therapies are therapies such as alemtuzumab that I mentioned, or stem cell therapy, which is a bit of a misnomer. It's really a heavy chemotherapy followed by stem cell salvage, which permanently reprogram the immune system. They are associated with significant side effects. They are potentially toxic therapies. So it's hard for us to motivate ourselves to use these therapies in children or very young people, where we have a chance of controlling the disease with approaches that are potentially less toxic. And using something like natalizumab, which is a therapy that acts on the periphery and stops the transition of the immune response from the circulation into the brain, is a very tempting prospect, because we actually not suppressing the immune system. We're just closing the door, we're sealing the borders But otherwise, we're not interfering with the immune system that much. So it is a dilemma. It is a therapeutic dilemma. Cladribine is probably slightly more acceptable approach to this, but also milder approach. It's not as profoundly immune reprogramming therapy. It's an immune reconstitution therapy that leads to initially transient decrease in both T and B cells and a few other cell types, and then repopulation of cells over the long term, and probably with some permanent qualitative changes to immune responses, but not as profound as chemotherapy with stem cell transplant or as alemtuzumab. And therefore, we don't quite know how sustained these changes will be, 10 or 20 years down the track from treatment with cladribine. But it could be a potential candidate for this type of approach in slightly milder spectrum of the and less toxic spectrum of therapies. I think in the end, again, we will be reverting to that concept that we have discussed in response to your previous question. We will identify people in whom we will need to reprogram immune system more substantially, and where the benefit of using substantial therapies such as chemotherapy with stem cell therapy, alemtuzumab, outweighs the risks. And where we go in early with these therapies, where the immunological patterns that we can measure and describe in these people tell us that this is the best strategy, and that we potentially either do not need to treat further, or we only treat with mild therapies as a maintenance. And there probably will be very large population of people who will not require this approach, and we will be able to, we currently are not, but hopefully in the future we will be able, with the help of immunology, to identify these people and make the decision that in these people we don't need to go for the most robust approaches, but we can choose a immune modulation of a milder caliber used over the long term.
Yes. Kind of like I loved watching Star Trek, and there was a doctor who had a scanner and kind of used all these biomarkers, and then knew what he should do. And of course, one basic guideline I think of medicine is as much as needed, but as low as possible. And this is always very important. And I don't want to see people like me be treated with an aggressive medication, because I'm on, EDSS 1.5 after 20 years. So it would be horrible if somebody would have treated me with high effective medication. I would have had more disadvantages from it. Let's come to an aspect of evidence-based medicine. What role do clinical trials play in shaping evidence-based medicine for MS treatments? And how do they contribute to the treatment guidelines, or let's say your ways of making decisions, and where are their limitations when it comes to the long-term outcomes?
Well, clinical trials are essential part of our discovery process. They tell us about the treatment efficacy, which in translation means, does a treatment work? So we find a population that is most likely to respond to that therapy. And that's why you see around trials, you see fairly strict exclusions. There can be only people of certain age, of certain volume of previous disease activity, of certain maximum disability or the greater disability, where we believe things can still be modulated. And then they are randomized to the target therapy, and in the past, typically placebo, which is a substitution for no therapy. I think the times of placebo-controlled trials in MS are gone, and we are really now need and are implementing different strategies, such as trials with active comparator arms. And as we have recently learned from a negative trial of a BTK inhibitor, also about a different strategies to choosing in comparator therapies in these trials, and different designs, such as non-inferiority trials, which will become a necessity in the space that is really saturated with very potent therapies. So this piece of evidence tells us if something works. That is an essential information, but it's just a foundation step. knowing that something works does not mean that it will work for everyone, to what extent it works, and how an individual interacts with that treatment decision and how previous treatment decisions interact with the treatment decision. And that's where we need the so-called real life. I don't like that term because I think everything is real life, including randomized controlled trial. There's just a section of it. So that's why we need observational data, where we have large volumes of information from people from different walks of life who make different decisions at different time points, and we can study the interactions about these different factors and where, for example, a certain new therapy fits in comparison to other therapies in the context of previous treatment exposures, in the context of the inherent disease activity.
Yes, and so I think you already explained it a bit. My next question, because I wanted just to ask you, how does real-world data complement the evidence of clinical trials in understanding the effectiveness? But you already explained it. So, but maybe you can just go a little bit in the details of the pro and cons of the real-world data, where it's hard maybe to make the comparison.
Yeah. Real data as opposed to the chocolate world data. So to expand on my previous answer, probably the right reason why I spoke about both in response to your previous question is that they belong together. They're part of the same process, and each of them or each group of studies answers different process. It will be naive to think that observational data can allow us to fully, without a bias, quantify the magnitude of effect of a certain therapy. And we need to work really, really hard to suppress the bias. Something that we call treatment indication bias is most prominent. It basically means that a neurologist and the patient choose the therapy for a reason. They will be more likely to choose more potent therapy in someone in whom they predict that the disease will become more severe. And I think your example, as you centered around your own story, is a very good example that someone in your instance made that prediction a long time ago that your disease is going to be fairly mild and that you will not require more potent and potentially more toxic therapy. So that leads to treatment indication bias, which we need to eliminate. And fortunately, we are able to mitigate it substantially with fairly sophisticated statistical methods, given that we have access to large volumes of data. But it will be also equally naive to think that we can solve all the questions in MS from randomized trials. It is naive to believe that in a randomized trial, you run a randomized trial, then you know exactly where the treatment fits and how it performs in comparison to all the other therapies, and that's all we need to know. So these two really complement each other, and both types of studies come with their own caveats. Randomized controlled trials are not broadly generalizable. They can only be applied in the populations that are very narrowly selected for the randomized controlled trials. They are very expensive, which limits their duration. So we can observe only the efficacy of the treatments for the limited period of time, typically 2 or 3 years. And that applies, while they are rigorous in collecting safety information, they do that also only within these limited timeframes. And in therapies such as B-cell depleting therapies, of course, the big question that we are facing now is, while B-cell depletion is reasonably safe in the 2 to 3 year horizon, and as we are learning from extension of the trials, which is typically one trial finishes, people who participate in a trial go in a registry that is followed over time, looking for adverse events of therapies. However, that extension is no longer randomized, of course. We can't. The answer that we're trying to get for the B-cell depleting therapies is what happens after 10, 20 years of consistent depletion of B-cells, and what long-term downstream effects this can have on a human organism. There's very little that we know about that, and we are very transparent about it. One of the questions, for example, that will stem from that knowledge, or that is being explored in parallel to that knowledge, is there a point at which we can choose to stop depleting B cells? Has the immune system been modulated enough and permanently that we do not need to worry about the deranged B cell anymore? They are all in line now, and the effect of certain duration of B-cell depletion, 2 or 3 years, will now last into the coming decades. So those are the main limitations of the randomized controlled trials. I mentioned the limitation of observational studies, the form of bias, the treatment indication bias, which we mitigate with statistical approaches. I guess the advantage of observational studies is that they tend to be slightly more generalizable, because these are, depending on the nature and the way that these data sets that are serving the purpose of the analyses are collected, defines how generalizable the new evidence is. If you have a large national population-based registry, such as Swedish registry or the Danish registry, or Canada has excellent access to healthcare data, then you can derive, make conclusions that are potentially applicable to the entire population, that are really unbiased, where the underlying pool of data leading to this analysis is unbiased, is representative of the population. And then you have other approaches, such as MS-based, which is more selective. That's this kind of self-selective approach to databasing. But it's so the disadvantage is that it's not a population-based registry. The advantage is that it does operate across multiple regions, so you get this very nice broad variability in the nature of conditions, contingent on ethnicity, the genetic background by proxy, the geography. So this type of resource allows people to study the behavior of the disease and the effectiveness of therapies in these all sorts of different contexts, not just a very specific narrow context in which a randomized controlled trial would be run.
Yes. How does patient understanding of multiple sclerosis and its disease course impact treatment decision, therapy adherence, and overall disease management, when it comes to shared decision making? And I mean, adherence is always or can be a big issue.
Yeah. It's absolutely essential, absolutely crucial part of the entire process. And we have put those times where of the very patronizing relationship between healthcare providers and patients behind. I certainly was raised in a very different model of healthcare, and I can see that the whole model is evolving in a positive direction further. So my conversations with people who come to our neurology center are always open conversations and sort of patient-led conversations, where our role is to provide guidance, information, and evidence. And some people, of course, do not want to process all the volume of information, so they entrust us with the decision, which is very entirely appropriate. I mean, in the end, that's what we go to school for. But it's important, of course. It's the person who implements or who enacts that recommendation is the patient, is the person living with MS. So it's absolutely essential to understand what the person is not willing to do, to give them enough information to be able to make an informed decision in an unbiased way, to understand the perspective and the roles, places of different pieces of evidence in that very large puzzle, and also to understand the uncertainty around evidence and the possibility of error. A very good example, I mentioned the diet, for example. It's something that people tend to be very religious about.
Yeah.
Even though the evidence for a particular diet is weak, or if there is any. And also, if people understand, if we help people understand that, coming to my previous statement, diet must play an important role in MS, but I can't tell you what is the right approach because we just don't know. That hopefully helps the person make up their own mind about what they want to do. They know that they probably can try something. They shouldn't hang everything on that decision and should be bringing other elements into their care. That means also adhere to potent therapy as appropriate for their disease severity, avoid risk factors such as smoking, try to control their BMI. But it is in the end the person sitting in front of me who's integrating all those decisions into one place. the other aspect is the motivation, and I'm not a psychologist. I will really leave this to a motivation psychology, which is a big area to explore. And I'm really an amateur in this area. But some people do not need motivation. To some people, the motivation is staying healthy, being active, being able to embrace their passions and pursue their life. Some people need a little bit more external stimuli. It gets complicated by other concomitant diseases, which are more prevalent in MS and may be actually biologically grounded, such as depression, for example. And in these instances, we do have medical ways of helping. And also there are lifestyle changes that can help in those instances. So these are the compounding factors that add to the motivation problem. And then there are, of course, there's this very complex area of the social backgrounds, and people from different social backgrounds and cultural backgrounds have different levels of motivations, dynamics within families, and how the cultural groups usually work together or do not work together to deal with these problems are also very important. I know I'm giving you a very vague answer because it is a very there is no guideline for how to navigate it. But I think if there was one central element, it is I do whatever I can to empower the person with MS to get them realize that they are in charge. I'm here to help them, but they are the ones making the decisions.
Yes, and Chelf, my neurologist, always says he is a trainer and I'm the player on the field. And I had a very nice interview with Ulrik Dalgas from Denmark, who explained how much sport can help, for example. And there's another one with Mireia Sospreda on diet, things that can be taken into account. So lots of fibers are good. Doesn't matter the direction, if it's Mediterranean or it can be, I guess, Southeast Asian as well. But to stay away a little bit from too much sugar, too much salt, I think that helps already quite a lot. Too much bad fat. Okay, but you answered already my second question. So we come now to the quick fire Q&A session. Complete the sentence. For me, multiple sclerosis is
an autoimmune disease of the central nervous system.
What development would you like to see in the field of MS in the next 5 years?
I would like to see personalization of neuroimmunology to drive therapy.
Yeah, and your explanation was really, really very. I mean, it's ambitious, but I really like that concept of making it very much to the point, to the patient. Okay, so finally, what message of hope or encouragement would you like to share with the individuals living with MS?
That we are very close, that it's exciting times, as I mentioned several times during this interview, and hopefully I have justified those claims with some mentions of research that has recently been completed in last 2 or 3 years, where we are becoming much more apt in understanding the pathogenesis of MS and how that understanding feeds into the development of new therapies or use of the currently available therapies. So stay tuned.
How and where can interested people follow your research activities?
We have a website, the Core Clinical Outcomes Research Unit at University of Melbourne. We have a website where we highlight publications that come from the team. The Neuroimmunology Center at the Royal Melbourne Hospital has also its own website where we sometimes feature research, and we also communicate through channels such as MS Translate, the ECTRIMS platform, and MS Australia.
Fantastic. Thomas, thank you very much. You answered really a lot of questions. I feel a little bit bad now for squeezing you so much, but it was very interesting and exciting times. I think so too. Thank you very much. And I'm looking forward to listen to another of your presentations. Probably not this ECTRIMS because my little one will be half a year old by then, but maybe then in 2025. Thank you very much.
It was a pleasure, Nella, and all the best for your little one. I'm sure it will be a lovely time.
Thank you. Bye-bye.
Bye-bye.
Thanks for listening to this episode. I hope you enjoyed it and learned something new and understood that it is really important to keep MS under control and that the window of opportunity is more at the beginning of the disease than later on in life. So high-efficacy treatments can be very helpful with that. By the way, next time I will be talking to Professor Christian Münz about EBV insights, shedding light on its impacts on MS. EBV is the abbreviation for Epstein-Barr virus, and as Christian is Professor of Viral Immunobiology at the Institute of Experimental Immunology at the University of Zurich in Switzerland, he is concentrating on that topic a lot and can give us really deep insight. So please tune in again. It's a very interesting episode, and I would appreciate it if you tell other people about this podcast or maybe rate it on the platform where you're listening to it. And of course, I would be always interested in things you want to know and episodes I should do. So please let me know, send me an email or contact me via Instagram, LinkedIn, Facebook, whatsoever. And stay as healthy as possible. See you next time. Bye. Thank you for listening today. I hope you found it helpful. You may also be interested in the previously published episodes and posts, which you can find at ms-perspektive.com/podcast. Perspective with a K. You can also get a free PDF with 11 tips for your positive impact on MS at ms-perspektive.com/newsletter. If you'd like to get in touch, you can reach me at nele@ms-perspektive.com or on social media. See you next time.